I'd like to welcome everyone to tonight's roundtable discussion. My name is Dr. Angie DiMichele, and I am a medical oncologist at the University of Pennsylvania, where I co-lead the breast cancer research program. Tonight's topic is addressing personal risk and racial disparities. This is a topic that is so important because breast cancer outcomes have dramatically improved with screening, and even the technologies for screening have improved dramatically over the last several years. We know now that we can identify women at particularly high risk and tailor our screening strategies to those patients. But importantly, screening is also underused in the community due to various barriers. So tonight, we're going to talk about these issues, and I can't think of anyone better to join us in this than the panel of experts we have tonight. So let me introduce our experts. First, we have Dr. Susan Doncic. She is the Executive Director of the Vassar Center for BRCA, Director of the McDonald Cancer Risk Evaluation Center, and the Vassar Professor in Oncology at the University of Pennsylvania. Next, we have Dr. Rachel Jankowitz. She is the Director of the Rena Rowan Breast Center and an Associate Professor of Clinical Medicine at the University of Pennsylvania. And finally, we have Dr. Lola Fayanju, who is the Helen Dickens Presidential Associate Professor, Chief of Breast Surgery at Penn Medicine, and Surgical Director of the Rena Rowan Breast Center. So welcome all of you. Thank you for joining us tonight. We're really looking forward to what you'll tell us about this important topic. So let's dive right in. And first, I'll start with you, Dr. Doncic. So let's just start with the basics. Can you tell us how breast cancer risk is determined and why it's so important? And particularly, how is your family history factored into this?
Great. Thank you, Dr. DiMichele. There are many components of what increases an individual's risk for breast cancer. And two of the most obvious ones are being a woman and being older. Now, men can get breast cancer and younger women can get breast cancer. And so this is the first element that we want to review, is that risk is just that. It increases your chance of developing cancer. It doesn't mean that you won't develop cancer if you don't have these risk factors. And it doesn't mean that you will develop breast cancer if you have all these risk factors. It just, if you will, weights it to one end or the other. So some of the things that we think about when we think about risk factors are reproductive risk factors. Getting your period at an earlier age and having your children later, for instance, both increase your risk for breast cancer a little bit. And you might notice that those are components of, if you will, living in a more Western society where girls are well fed and nourished, and therefore they tend to get their periods earlier. And because there's more women that go to college, they might have their children later. And so these are just elements of society that can impact breast cancer a little bit. Other things, birth control pills or taking postmenopausal hormone replacement therapy also increase the risk of breast cancer a little bit. There's also modifiable risk factors. And for that, we mean being overweight increases your risk, not exercising increases your risk, and maintaining a healthy all-around diet, and particularly minimizing alcohol can really decrease your risk of breast cancer. So those are things that we feel are modifiable. Another big component is breast density. We're going to probably talk about this more, but when you get a mammogram, if your breast tissue is very dense, it can be hard to see cancers in the breast tissue. But breast density itself is a risk factor. So it's not just that it hides the cancer, but it actually does increase your risk of breast cancer. And finally, we come to family history. I think we're going to talk about that more as the evening goes on, but family history is nuanced because having your mom diagnosed at 80 does increase your risk of breast cancer a little bit, but much more, it increases your risk if your sister's been diagnosed at 35. So it really depends on the details of the family history, and not only whether there's breast cancer in your family, but whether there's other cancers in your family.
Wow, thank you. That was really helpful. So if a woman, or a man for that matter, want to understand their risk of breast cancer, what kind of information should they gather and how should they convey that to their healthcare provider?
Well, one thing is that family history is very, very important. And it wasn't that long ago that individuals didn't talk about cancer. That we didn't really exactly know what Aunt Janie died from, just some female cancer. We didn't really know anything more than that. And maybe the word cancer wasn't even really used. And this really shortchanged people because knowledge of your family history is critically important to understanding whether or not you should get screened more intensively or at an earlier age. So things matter like what relatives had cancer, what ages did they have cancer, and even more importantly, what does that family structure look like? You can imagine that if you have, 24 female cousins and no one has had cancer, that's very different than if your mom's an only child and your dad is one of 5 boys and you only have male cousins, right? So these things matter, and it's really important to kind of bring that to the table with your healthcare provider. And one thing that's always bothered me is it's not like, did your mom have breast cancer? It's, do cancers run in your family? Because it's just as important that your dad's side of the family has breast or ovarian cancer in it than your mom's side. You can inherit genetic susceptibility equally from your mom or from your dad, and you can't ignore your dad's side of the family. So obtain that information. What did your relatives die of? At what ages? What cancers did they have, to the best of your ability? And then bring that up to your healthcare providers.
Great, thank you so much. So we've talked about risk. Now let's talk a little bit about screening. And to start us off on that topic, I'm going to turn to Dr. Jankowicz. So Dr. Jankowicz, what are the screening recommendations right now for a person who has average risk, and how might those recommendations change if that person actually has a higher than average risk? For example, if they have a strong family history, like Dr. Doncic was talking about.
Thanks, Angie. Yeah, so we're pivoting now to talk about women at average risk. You just heard from Dr. Domchek about how much family history can increase risk, but it still holds true that a lot of patients get sporadic breast cancers without any family history. And so how do we approach screening for patients at average risk who have no clear-cut reason to be at elevated risk for breast cancer? The screening guidelines from the American College of Radiology recommend screening with mammography once a year, starting at age 40. The American Cancer Society similarly recommends annual screening for women ages 50 and older. And then they also talk about age 40 to 44, that patients should have the choice to do annual screening once a year. And ages 45 to 49, they should be screened with mammography annually. Other guidelines exist, and there are guidelines amongst the American College of Physicians and the American Academy of Family Physicians that use a bit more choice language for younger patients between the ages of 4 to 49, and they talk about the importance of talking about benefits and risks of screening with individual patients. So it can get a bit confusing for clinicians, actually, if you start looking at all these various regulatory bodies and their screening recommendations. But the take-home message is, for patients 40 and older, one could argue that many guidelines say that it should be a choice for women to screen annually. For women ages 50 to 74, we also are going to endorse annual screening. There are some guidelines that endorse screening every 2 years, but generally the American Cancer Society guideline is annual. So obviously this needs to be a discussion with the patient and their treating physician. And when you think about negatives of screening, there can be a risk of false positives. But of course, the benefit of screening is early detection of breast cancer.
Great. So we've talked about age and frequency of screening. Can you tell us a little bit about the different types of tests that are used for screening and when those different tests are used?
So the fundamental backbone of breast cancer screening will always be mammography, and nothing replaces mammography, and that doesn't change. There are additional tests that one can do for patients at elevated risk. For instance, if they have identified a hereditary mutation, such as a BRCA mutation, we would recommend annual breast MRI in addition to their annual mammogram. And often that will be done on a staggered schedule so that they're getting one study every 6 months. You can also use the screening MRI for other patients at elevated risk of breast cancer who have been estimated to have greater than a 20% lifetime risk of breast cancer. And we do offer at the University of Pennsylvania, for instance, a breast MRI for screening, which is a rapid MRI protocol. And so there are the options to enhance screening with MRI, and that would be considered the gold standard or the most rigorous way to screen for breast cancer with that alternating MRI mammogram schedule.
And for either Dr. Doncic or Dr. Jankowicz, where does the ultrasound fit in here? Because many patients ask, should I have an ultrasound every year?
Sure, I'll hop in and have others join. In general, the studies have shown, particularly if MRI is already being used as a component, there really isn't any added value to ultrasound. I think one of the areas that is in flux is in individuals who have very dense breast tissue. Mammography may not be sufficient. And so there are multiple different kind of guidelines and suggestions. And if you get your mammogram done in Pennsylvania, you get a little extra caveat on your breast report about dense breast tissue, about whether or not an ultrasound or an MRI should be added on to your mammogram if you have extremely dense breasts. And I think that this is where there's a little bit of a regional nature to it. Automated breast ultrasound is something that people really kind of hope to really gain speed. But ultrasound right now is in many places operator dependent. And so we at Penn mostly do for those extremely dense breast tissue patients, we do rapid MRI rather than ultrasound. And I don't know if, Lola or Rachel, you have anything to add to that.
Well, I think that you kind of alluded to the fact that the use of screening ultrasound is dependent on the operator, and there is a learning curve. It's labor intensive, and it can have false positives if it's not done in high volume. So that can be challenging for individual institutions to implement, I think. And I'll stop at that.
Yeah, I agree completely. I think another important thing for patients to feel reassured about is that if your radiologist thinks that you need an ultrasound as an adjunct to your diagnostic mammogram, that will be performed. So our radiologists are incredibly well attuned to for whom ultrasound is an important adjunct, and so you can have faith in your radiographers about that.
Yeah, that's a great point.
Just to clarify that point, because it's so important, the difference between a screening test and a diagnostic test. Screening tests are you come in, you have no trouble, you come into the radiologist for your annual exam. Diagnostic testing is you feel something, your doctor feels something, or they might see something that looks a little weird on your mammogram, and then you'll get whatever test is necessary to work that up. And that often includes ultrasound. So it's such a really important point.
Great. So we've talked about the standard mammogram. We've talked about MRIs, fast MRIs, ultrasounds. Dr. Fayanju, maybe you can also speak to this new term tomography as it applies to mammograms. What's that all about if a patient hears that they've been recommended a tomogram?
So tomography refers to the idea of a 3D mammogram. That is, rather than just taking your mammogram in two planes, that is the craniocaudal plane, that is looking from the top of your head down to your feet, or the mediolateral plane, which is looking from the middle of your chest, either to your right or to your left. Instead, we're doing a completely 360 in multiple directions, so X, Y, and Z, examination of your breast. And then what we look at, or at least rather what the radiographers look at, is multiple cuts of that image. So if you ever had a CT scan, for example, that is the type of study where you are moved slowly through a machine that basically takes images of very, very finely separated slices of your body so that it can see every little bit over the course of a larger area. And that's now basically been applied to a mammogram. And what this allows us to make sure of is that we can catch even very small, discrete lesions. Let's say that they aren't perfectly viewable in a particular phase or a particular view. You can catch it even if it's just in a view that isn't the standard craniocaudal or CC or standard ML medial lateral view. So it has allowed for improved detection of more subtle lesions. And it is really the standard of care and what we would expect any woman in the United States to receive for her screening mammogram or diagnostic mammogram. This is very important because if you're offered anything other than a 3D mammogram or tomography, you should seriously reconsider where you are getting your mammography care, because that is not what we really consider standard of care any longer. And that is something that's important to realize as a contributor to disparity. It is not just whether or not screening mammography or diagnostic mammography is available to all women, but what is the quality of that mammography? And also what is the expertise of the people who are reading those mammograms? Because if you have individuals who aren't as experienced with reading mammograms, especially in people who have dense breasts or what have you, we may have an opportunity where someone's getting the false reassurance of an improperly conducted test.
Well, that certainly is so important. And I want to just follow up on your comments, Dr. Fayanji, because I know you do a lot of work with disparities. And that's a term we're hearing a lot about, but I want you to maybe tell our audience about how disparities play out in this issue of screening.
So just to clarify, so a disparity is a difference in health outcomes, screening, treatment that is not based on the choice of the patient or frequency of a condition in a particular group related to the biology of the group. It is basically something that's rooted in what we would argue is injustice. That is, it's a remedial form of difference that we ideally could do something about. And so with regards to screening, in the United States, we actually have fairly comparable rates of screening now across ethnic and racial groups, with a notable exception of Native Americans, who continue to have lower screening rates between the ages of 55 and 64 as compared to other groups. But the groups are not that different when you compare Black women, Latina women, Asian women, and white women. The rates are not as different as they once were, which is a credit to the outstanding work done by Komen and other advocacy groups to promote understanding of its importance. However, what we are seeing is, as I already mentioned, differences in the quality of mammography, differences in the expertise of the people who are interpreting mammography. We are also seeing that people may not have the same level of follow-up for abnormal screens. So that is, you go for your screening mammogram, you think it's the body that you're going to check off this year, and then you get the call back that something else needs to be done. And there is some concern that people aren't coming back from certain groups to get that follow-up mammogram, or that they're lost to follow-up. And the reasons for that are multiple and complex, but it is an important area of study that people from Penn are also investigating, and that we're hoping to learn more about how to intervene upon that issue. The other issue that's really relevant to what we've been discussing is when screening should begin. And we know that there are certain groups for whom there are higher rates of what we call premenopausal or early breast cancer. That is breast cancer that's likely to be diagnosed prior to the age of 40, which is when, as you heard from Dr. Jankowitz, many groups recommend you at least start thinking about getting screening. So one thing is that if you have a family history of breast cancer, we typically recommend that you should begin screening, let's say it's a first-degree relative, 10 years before that person was diagnosed. But of course, you need to know that they have a diagnosis of breast cancer. And you'd be surprised how many people in certain groups that are more loath to talk about family history of breast cancer don't know that's the cancer that their mother or their sister had. So that's one issue. The second issue is that we know that Black women are at higher risk for premenopausal breast cancer, that is, cancer diagnosed women who have not yet achieved menopause, and therefore is more likely to be symptomatic because it will not have been picked up as part of a screening program. So we who are interested in disparities in breast cancer, which is really everyone here, really are very concerned about these guidelines that emphasize the need to wait till 50 or to 45 or to 40. We actually think that an important part of primary care for all women should be risk assessment. That is, knowing whether you are at average risk much earlier in your life. Ideally, starting around the age of 30, you would have a sense of whether or not you are an average or high risk person, and then you can make an informed decision based on that risk assessment. Now, one important caveat is that many of the risk assessment tools, that is, statistical models that have been developed using thousands of patients' data to assess whether someone's at high or low risk, are underpowered to assess risk in certain ethnic and racial groups, namely Hispanic, African American, and Asian women. So again, keeping that in mind, we are at risk of under-screening people who may be at high risk but don't know they're at high risk from certain racial and ethnic minority groups. So that is to say, as my professional society, American Society of Breast Surgeons, strongly advocates for getting screening mammography every year at the age of 40, and I do endorse that. There are many Black women for whom their first mammogram is the mammogram at which they're diagnosed with breast cancer. And even more unfortunately, there are women who never make it to that first mammogram and are diagnosed with a very aggressive breast cancer. The last thing I will say is that premenopausal breast cancers are not only more likely to be symptomatic, they're also more likely to be quite biologically aggressive, that is triple negative or requiring chemotherapy. And so again, for many reasons, early risk assessment and then appropriate initiation of screening are very, very important for racial and ethnic groups that are at risk for early life disease that can be very, very challenging to treat.
Thank you. That's such an important issue. I'm wondering if you could tell us at all about any community-based efforts to try to improve this situation, both in terms of getting people to screening and then making sure patients get to care if they have an abnormal mammogram.
So there are a lot of programs that work to encourage women to not only go to their mammograms every year, but to bring a friend. When I was in North Carolina working at Duke University, I worked with a fantastic community organization called the Sisters Network, which is an advocacy and support group across the country for African American women survivors of breast cancer. And there are local chapters. And the chapter I worked with in North Carolina had what's called a T for Two, which was when you came to the event as a survivor, and you often were encouraged to bring someone else. But then in addition, they were distributed, people received cards that gave you an opportunity to remember when your last mammogram was, and therefore when you should get your next one. You filled out your card there and it was mailed to you so that you had it kind of coming to the mailbox to you right around the time that you were due for your mammogram. So that's an example of the type of program that can encourage people to get their mammograms on time. And we know that throughout the COVID-19 pandemic, there's been a delay in people getting their screening mammograms because of, one, the initial pause that occurred in the spring of 2020 in order to avoid contagion, both of healthcare providers and of patients, but also that the disproportionate effect of the COVID-19 pandemic on communities of color has meant that there's been a higher rates of job loss, higher rates of insurance loss, higher rates of worsening of other comorbidities, such that screening for asymptomatic disease has not been prioritized by certain groups because of competing concerns such as inadequate childcare and job loss. And so that's all to say is that we're in a very tricky time as we try to emerge from the COVID-19 pandemic to help people resume screening. We had an event at Penn this fall, a mammothon that was really successful and got many people, employees, patients, back on track for their annual mammograms. Another potential important way of getting people to mammography is mobile mammography, that is mammovans. Our colleagues in the Penn Medicine System at Pennsylvania Hospital have been working to get that set up and had a very successful several days working in different communities to bring mammography to the people. So those are examples of ways in which we can improve screening mammography. Because again, I think people are aware, it's just actually making it there and making it easy for people to get the screening they should get.
Absolutely. Thank you so much. So let's switch gears again and now focus a little bit on inherited breast cancer. And Dr. Doncic, you clearly are an expert in this area. The Bassler Center does a lot of work in this area. So help us understand what an inherited risk of breast cancer really means. And then with regard to the genetics of this, how does race play a role?
Absolutely. So most people are familiar with the genes BRCA1 and BRCA2, thanks to Angelina Jolie. These genes just stand for breast cancer 1 and breast cancer 2 because, we're really not that creative in medicine. And they're not the only genes, but they're the first ones that were discovered. And what we know about these genes is that everyone has them and they have good roles in the cell. They're good genes to have. It's if you have inherited a bad copy of one of these genes, something we call a mutation or a pathogenic variant. If you inherit a copy that doesn't work, that increases your chance for the development of cancer. It doesn't mean that you will get cancer, it just increases the chance of developing cancer. But that risk of breast cancer can be up to 70%. The risk of ovarian cancer can be 40%. There's an increased risk of male breast cancer, of prostate cancer, of pancreatic cancer. So it's not just one cancer, although breast cancer is the one that tends to dominate everyone's minds. But breast and ovarian cancer are the two key cancers. And there are things that we can do if we know that individuals inherit these mutations, and we can help with an early diagnosis, and we can also reduce the risk of cancers by different approaches. So it's important to recognize who has these gene mutations. And gene mutations in BRCA1 and 2 are in individuals of every race and every ethnicity. And I think this is something that is sometimes poorly understood, because it is true that that more individuals who are of Ashkenazi Jewish descent have these mutations. So 1 in 40 people who are of Jewish descent have mutations in one of these two genes. But in general, 1 in 200 people have them. So whether you're Black or Asian or white, it doesn't matter. It's about 1 in 200. So it's still pretty common. And we know that there are risk factors: young age, triple negative breast cancer, which was alluded to earlier, the presence of ovarian cancer, aggressive prostate cancer, pancreatic cancer. So these are all things that we look at in the family when we think about genetic testing for these. We also, though, know that there are a lot more genes. It's not just about BRCA1 and 2. There are a lot of other genes as well. So these days, we don't just send testing for 1 or 2 genes. We tend to test for a panel of genes. And one thing that tends to prevent people from coming in to see us or talk about their doctors is that they're really worried it's going to be hugely expensive, because sort of word is out on the street that these tests cost thousands and thousands of dollars. But it turns out they don't. If you have the appropriate, family history or personal history, they're usually completely covered by insurance, sometimes with maybe $100 copay. But even when we don't use insurance for one reason or another, it's $250. And I'm not saying that's still a cost, believe me. But for most people, it doesn't cost anything. And we do have all sorts of approaches to basically get the tests covered that need to be covered. So I just want to have a big shout out there that these tests do not have to be expensive. And it's really important that it's for everybody. People need to know their family history. They need to know what type of cancer they have, and they need to ask, is genetic testing the right thing for me? And sometimes the risk is really low, but your doctor should be able to tell you that, okay? And certainly if you're young, if you're under 50, you have triple negative breast cancer, you have ovarian cancer, pancreatic cancer, metastatic prostate cancer, all of these people need testing regardless of their family history. And there's other lists, but just don't be hesitant to ask your doctor, because what has been shown is that even though there is not a difference between, if you will, Black women and white women that are not Jewish in terms of how often they have mutations in these genes, the fact is that there's a big gap in how many Black women versus white women get tested. Black women are much less likely to have genetic testing. And that's in part because even when they ask their doctors, they sometimes don't get access to these tests. So this is where we have really been keen on making sure that these disparities go away, that anyone who is eligible for these tests get them. We're trying to do this in a number of different ways, enhance different kinds of ways to do pre-test education. My colleague Angela Bradbury has a whole digital health kind of platform. We've done videos, telegenetics, we're trying all sorts of things to make it as easy as possible. But I think the key is that one of the big barriers is the cost. And the second big barrier is that physicians don't recommend the testing to patients. And so our goals are not only to talk to patients, but to talk to providers to make sure that they're aware that people need to be referred in for genetic tests, because it can help prevent cancers and it also can help us treat cancer.
Great, thank you. So on that note, treatment, let's shift gears a bit again and talk a little bit about treatment plans once a patient is diagnosed with breast cancer, and how genetic results might factor into that. And so, typically surgery is one of the mainstays of treatment. So Dr. Fayanju, can you talk a little bit about how you form a surgical treatment plan and where the genetics might factor into that?
So you're right. Obviously, surgery is often the first step in treatment, but increasingly, we really need to have a multidisciplinary approach to the management of even early stage disease. One of the fortunate positions we find ourselves in with breast cancer is that we are actually worried about overtreating some people, that maybe we need to have a more selective approach to who gets surgery and radiation. And so one of the things that we're learning about is that if we know that, for instance, radiation or endocrine therapy or what have you are the kinds of adjunct treatments that help prevent recurrence far in the future, it's not clear that someone who is, let's say, over the age of 70 or 75 needs to have all of those things. That's all to say is that right up front, we're having a personalized conversation that's thinking about a patient's goals, both long-term and short-term, with the input of medical oncologists such as yourself to make the right decision for our patients. If someone has an early stage cancer that's fed by hormones, specifically estrogen and or progesterone, and it's small relative to the size of the person's breast, and there's no lymph node involvement. The lymph nodes we're concerned about being the ones under the arm or the axilla, the ones by the collarbone or the clavicle, and the ones in the middle of the chest off of the aorta, the internal mammary nodes. So long as those things aren't involved, typically those patients can go for surgery up front. And the question is whether or not they go for either lumpectomy, which is removal of just the area of concern with preservation of the breast, or mastectomy, which is removal of the entire breast. Increasingly, we find that in America, we have high rates of women choosing mastectomy at a young age, as well as choosing to have bilateral mastectomy, that is removal of both breasts. Ultimately, it's a personal choice. For the majority of small early stage tumors can be managed with lumpectomy. And if someone is healthy and has a life expectancy of at least 10 years and under the age of 70, we typically recommend radiation after lumpectomy to sterilize the breast and make sure there aren't any rogue cancer cells left behind that we can't see under the microscope. Some people choose, however, to have mastectomy, and that can be done with or without reconstruction. If someone chooses to have reconstruction, there is then the additional decision tree as to whether they choose to have their own tissue used, either from their stomach or from their back, or implant-based reconstruction. But people are also increasingly making a choice of having no reconstruction, and there's a real movement to embrace, going flat after mastectomy. An important thing for people to know is that mastectomy leaves someone completely numb. That is, they have no sensation in their chest wall after mastectomy, even with beautiful reconstruction. Now, that being said, mastectomy is the right decision for many women for issues of extensive disease, for symmetry if they want to get reconstruction, or for a sense of peace of mind that some of them may feel afterwards. And of course, for people who are mutation carriers, as Dr. Doncic has mentioned, mastectomy may be the right choice for them, including bilateral mastectomy, to decrease their risk of future breast cancer. But for the average risk woman, there is no survival benefit to having bilateral mastectomy. And for most women with early stage disease, the long-term outcomes between lumpectomy and radiation or breast conserving treatment versus mastectomy are comparable. Where we go from there is someone has something beyond just a small in-breast tumor. If there is lymph node involvement, then we may have conversations with medical oncology as to whether or not surgery should happen first or some type of systemic therapy or medication should be given to try and shrink either the tumor in the breast or under the arms. There are other types of breast cancer that we know, based on the biology of the tumor, that they would benefit from getting chemotherapy up front, even if they are relatively small. And those are tumors that are either not fed by hormones at all and don't have the HER2 protein, that is triple negative breast cancer, or tumors that are HER2 positive, that is, they have the HER2 tumor with or without the hormone feeding or hormone receiving receptors. So in those conversations with those patients, again, it's a conversation with our medical oncology colleagues. Do we want to proceed with systemic therapy first or with surgery first? The great news about providing systemic therapy first, as we've learned, is that there is no concern about survival. Early on in the early trials, as you know, the concern was if we wait to cut the cancer out, is there a risk of the cancer spreading? But in fact, we know that there's no risk. And indeed, there's a lot of benefit to getting chemotherapy first if you have a large tumor with aggressive biology. It teaches us, as you all know too well, whether the tumor is going to respond to treatment. It can sometimes, really importantly, shrink the tumor in the underarm or in the axilla to the point where we can do much less extensive surgery. And this is hugely important for patients because we know that having to remove a lot of lymph node under the arm put women at increased risk for lymphedema or swelling of the arm, as well as other types of range of motion issues. So whatever we can do to minimize surgery under the arm, we really benefit from. And that's something we can credit you in the medical oncology world for making easier for our patients. One important development that's also important to know about is that when we look at the breast, we also always want to look at the underarm if someone has what we call invasive disease, that is breast cancer that is not just confined to the milk ducts of the breast. Invasive disease means that a cancer, by virtue of getting out of the milk duct, has the ability to go to other parts of the body. And so our goal is not only to treat the cancer right where it is, but to stop it from where it might want to go. And the first place it tries to go is the underarm or the axilla, where the lymph nodes exist that we check the most. For someone who has no evidence of disease underneath their arm, the first step is obviously to check a few of those lymph nodes and make sure there's no cancer in them, what's called a sentinel lymph node biopsy. And that samples the lymph nodes that are the sentinels or guardians of the breast, doing the most work of draining the breast. Removing those lymph nodes doesn't mean that those lymph nodes have cancer. It means if cancer were to go somewhere outside the breast, they would be the first stop. So if we get them out and they don't have cancer, then we can feel really confident the rest of the lymph nodes don't have cancer, basically 97% confident. And so the good news is we are increasingly able to do sentinel lymph node biopsies, that is selective lymph node sampling, for patients upfront and after chemotherapy, even if they started off with having a little bit of disease under their arm. So that's all to say is that we are working so well together now in breast cancer to really be able to give patients personalized selective care that decreases some of the morbidity that comes from aggressive local regional, that is surgical and radiation treatment.
So let's get you back into this conversation, Dr. Jankowicz. Along those lines, as a medical oncologist, Dr. Fayanju mentioned that there are systemic therapies and there are many reasons we use them, even in a newly diagnosed patient. Can you speak to some of the developments in this area?
Yes, thanks. Thanks, Dr. DiMichele. I always tell patients, Dr. Fayanju's in charge of the breast and I'm in charge of the rest. So my main job is to try to prevent metastatic disease. And I think the biggest advances that we've seen on the medical oncology side include a more keen understanding of differences in various breast cancer phenotypes or subtypes of breast cancer about how we can accomplish that goal. And for some of our higher risk breast cancers, we've now moved toward preoperative treatment for even smaller tumors. And things like that Dr. Fayanju just talked about, treating triple negative and HER2 positive breast cancer preoperatively with chemotherapy and other medications have allowed us to assess response to those therapies in real time and then tailor our approach after surgery accordingly, because we know that the response to these preoperative treatments helps inform our thoughts about prognosis and risk of recurrence. So one big change that's happened very recently has been the use of immunotherapy, for instance, for triple negative breast cancer. So we now are routinely offering many patients with triple negative breast cancer preoperative immunotherapy with pembrolizumab in addition to their chemotherapy. This has improved the likelihood that we will achieve a complete response or a pathologic complete response, and it's been shown to decrease the likelihood the patient will have a recurrence of their cancer, which is ultimately our main goal, not only to achieve that complete response in the breast, but to prevent spread of cancer to other parts of the body. Similarly, we are using preoperative therapy for HER2-positive breast cancer to inform our approach after surgery. So we now have the opportunity to offer patients who do not have a complete response to their preoperative HER2-positive treatments to different drugs in the adjuvant setting or the postoperative setting, but we can avoid use of drugs like TDM1 if the patient has a complete response, but then we can get a huge benefit from using TDM1 postoperatively if they don't have a complete response. So it's a more individualized approach based on response. Finally, we've also seen huge advances for our patients with stage 4 disease in many different settings. For the HER2-positive breast cancers, we have new drugs like Trastuzumab deruxtecan and tucatinib, both of which are showing exciting advances in treating patients with HER2-positive breast cancer, even in their central nervous system, which is a great advantage to us because previously we had a really hard time getting our drugs into the central nervous system. So we've seen advances there as well. For our patients with hormone-positive breast cancer, we also have an opportunity now to offer adjuvant abemaciclib, or that's a CDK4/6 inhibitor that we can use after surgery for high-risk patients to lower risk of recurrence. That is also newer. And finally, for our patients with the hereditary BRCA mutations that Dr. Doncic mentions, we can use PARP inhibitors after surgery to lower risk of recurrence. So it's very complicated according to the different types of breast cancer, but the good news is we're thinking about this hard. We're trying to tailor what we do according to risk instead of just doing a blanket one size fits all for all patients. And that's been really exciting to see over the last decade, the opportunity to do that.
Yes, and I think we would all agree that, we wouldn't have these advances if it wasn't for clinical trials, because that's how we test drugs. And certainly, millions of women probably now have participated in clinical trials, and we have foundations like Komen who've been so supportive of these. So maybe in our last few minutes, Dr. Jankowicz, you can tell us more about what is a clinical trial, how do we figure out if it's right for a patient, and importantly, how do we reach out to women who may not know about these, women who may not have access to clinical trials?
So I always tell patients that everything we do today to treat breast cancer is built on the backbone of patients that have participated in clinical trials in the past. It's probably one of the most evidence-based fields of medicine you'll find. We're not winging it. We're doing it based on clinical trial evidence in the past. So when a patient is thinking about participating in a clinical trial, the goal of that clinical trial is often to take what is currently the standard of care and tweak it somehow, to add another treatment that will either increase the likelihood of a response in their cancer and ultimately improve their outcome. And importantly, because we're trying to improve their outcome, we definitely don't offer participation in trials that would not be viewed as equivalent to what is currently the standard of care. So that's one take-home point that we need to drive to patients, that they will still receive what is currently considered standard. It's just the trial offers them the opportunity to potentially add something to that. So most often that's the conversations that we're having. In terms of access to clinical trials, we tried to approach all patients about clinical trials, but I think depending on their own pre-existing understanding or apprehensions about clinical trials, it sometimes takes a lot of time to talk about why we're doing it, what the pros and cons are, and it's often more time consuming to have that conversation, but it's really important to have that conversation in the clinic. And I know you yourself have done a great deal to try to improve access to clinical trials and are still doing that by hosting our metastatic breast cancer meeting group that we're trying to outreach to all of our network Penn sites and make sure that they're more aware of the trials that exist, so that we're not just offering trials to patients downtown, that we're trying to gain access to trials for our community sites as well. And so that's a hugely important endeavor to continue. So thank you for starting that.
I did want to also shout out Carmen Guerra at the Abramson Cancer Center for her work. We started this conversation talking about disparities, and I think this is another area where over time there's been significant disparities in who accesses clinical trials for a number of reasons, including just again, whether or not your physician brought that trial up to you, but also, what it takes to be part of a clinical trial, because often it does take a little bit of extra effort. It takes a few extra appointments. That means time off. So Carmen Guerra has done a really amazing job in working on this. The Abramson Cancer Center does have really a goal of equity, and we've done a really great job in increasing participation in underrepresented minorities, but we're not done yet. We also have a collaboration with the Lazarus Foundation to try to help with costs of clinical trials. And so, again, not done yet, not resting on our laurels, but it is really important, because unless we offer clinical trials to everyone, we're not demonstrating the value of them in everyone.
I agree.
I just want to echo what everyone's been saying. I conducted a study a couple of years ago that demonstrated just that Hispanic and Black women were about 20% less likely to participate in clinical trials, and that as compared to their proportion of the population, only about 2 to 3% of them participate in clinical trials. And as people mentioned, one of the deficits in that interaction is that they're just not asked. No one tells them that they might be eligible. But another issue that kind of lies with us as clinicians and with the people we hire to recruit patients for trials is the language and the messaging of the trial recruitment material. I think one thing that's been very interesting, and one thing that we saw in the study we conducted, is that actually amongst Black women, we found that those who were higher income were less likely to participate in clinical trials than those who were lower income. And that may seem kind of paradoxical, because as we discussed, we know that trial participation sometimes has more onerous burdens in terms of transportation and cost of participation, et cetera. But what we do when we ask someone to be in a clinical trial is we are asking them to extend an even greater level of trust to us than we do as their clinicians. We're asking them to say, there are these two options, one of which is standard of care, as Rachel said, the other of which we think may be the next big thing. We have equipoise about it right now, but we just don't know. And a lot of patients who come from backgrounds and from groups who have been historically treated very poorly are very reluctant to sacrifice or give up the choice that they have in their treatment by agreeing to randomization. And indeed, I've spoken to groups who have said, I don't like that word random in randomization, because it sounds as if their care is being left to chance. And so having to explain that what randomization does is it allows us to create two equally created groups who are very similar along multiple dimensions demographically. And that way, because we know we have two very similar groups, we can isolate the effect of the thing that's being tested and know that if we see differences, it's because of that thing being tested. So explaining to people what the purpose of a clinical trial structure is something that we need to work on too as a medical community. So people have the faith in us that we're frankly asking them to give, even though there has been historical and even current mistreatment of certain groups.
Well, this has been a wonderful conversation, and I think ending on those comments is particularly important tonight, because we've really touched on a lot of different topics: risk, screening, inherited cancer, how we treat cancer, clinical trials to help us develop new therapies. But really underlying all of this is that unless we find a way to reach out to be able to provide access, equity, and gaining access to these treatments, we won't be able to help everyone. And I think that you've heard tonight how our experts are thinking about this, the actions that they are taking to try to remedy this situation, as well as some of the programs that now exist here at the Abramson Cancer Center and elsewhere, really to start to attack these disparities and make these incredible resources and tools available to all. So I just want to take a moment to thank all of our panelists who've just been wonderful, Dr. Susan Doncic, Dr. Rachel Jankowitz, Dr. Lola Fayanju, as well as thanking the Komen Foundation for sponsoring tonight's event and all of you for your attention. Thank you so much for joining us.